Corynebacterium diphtheriae is that bacterium that I mentioned will resemble Listeria under microscopy, with the only difference being that the bacteria can be irregularly shaped and some can be not uniform in size. Whereas Listeria, they all tend to be very uniform, and they really are just short rods. Corynebacterium diphtheriae, you see there are some that look a little more like a coccobacillus, very small and kind of compact. Some are a little bit longer. So there's less uniformity. On growth media, they will form large colonies. They can be cultured on blood agar, but I'll tell you in a little bit why that can be challenging. There also is a special type of media that will enrich for this particular species. The bacterium is found worldwide. However, we see low rates of this bacterium in countries that have high rates of vaccination. I included this headline here: the first case of diphtheria in Spain since 1986, after the parents shunned vaccination. These parents of, I believe, an 8-year-old boy in Spain were against vaccination, or chose not to vaccinate because they thought these diseases didn't exist anymore. And unfortunately, their child got diphtheria and died of the infection. This is a headline from a few years ago now, but still, this was the first case in over 30 years of diphtheria in Spain, which goes to illustrate how effective vaccination is in controlling the infection. What happens with diphtheria infection is not necessarily that the bacterium is causing the symptoms of the disease. This is going to be a lot like Bacillus anthracis infection, in that the symptoms of the disease are actually caused by toxin production. There are some strains of Corynebacterium diphtheriae that have been infected by a bacteriophage, and that's what they're trying to illustrate right here. Those strains that have been infected by this particular bacteriophage produce an AB exotoxin. So remember, an exotoxin is a secreted toxin. With AB toxins, the B domain binds to a receptor on our host cells. The A domain is the active domain or action domain that gets internalized and does whatever effect it is that it's going to do. In the case of Corynebacterium diphtheriae and diphtheria toxin, the effect of this toxin is to inhibit protein synthesis by interfering with elongation. Specifically, the toxin binds to elongation factor 2, EF2, preventing it from working. The host receptor that diphtheria toxin uses, that binding domain of the toxin, is a heparin-binding epidermal growth factor. This is a relatively common receptor found on multiple cell types in eukaryotes, including us, and is particularly enriched in cardiac and nervous system cells. When a patient has diphtheria, the main symptoms of the disease are going to be respiratory, and symptoms will begin 2 to 4 days after exposure to the bacterium. This allows the bacterium to have enough time to colonize the upper respiratory tract and to begin producing the toxin. The early symptoms are going to be things like tiredness, sore throat, and the production of an exudate. And what is diagnostic about diphtheria is the formation of this structure called a pseudomembrane. The pseudomembrane is illustrated really well in this bottom image, where you could almost mistake it for strep throat, right? You see that yellowish discharge on the back of the pharynx. But what they're illustrating kind of up here as well is if you actually try to scrape that away, it removes the host tissue and leaves like a raw area where the tissue has been destroyed. Because when you interfere with protein synthesis, cells will eventually die. Myocarditis and neurotoxicity can develop if the tissue destruction is severe enough that the toxins can get into the bloodstream. You almost never can culture the bacteria from the bloodstream. It's really the production of the toxin and the toxin getting into the bloodstream that causes the issues. One of the other major concerns with the pseudomembrane is that it can grow so large, it can start to cover and grow on the epiglottis and block the trachea, which can cause death from respiratory failure. If the bacteria happens to get into wounds, like on the skin, it can cause a cutaneous form of disease. And again, just to highlight here where you have this raw area if the pseudomembrane gets scraped away. This is a case study of the last patient with diphtheria diagnosed in the US. This was back in 2004. An unvaccinated 63-year-old man developed a sore throat while on a trip to Haiti. After he returned home, 2 days later, he visited a local hospital with complaints of a sore throat, difficulty swallowing, very standard upper respiratory symptoms. He was treated with oral antibiotics, but returned 2 days later with chills, sweating, difficulty swallowing and breathing, nausea, and vomiting. Remember, the major symptoms of this disease are mediated by toxin production. So treatment with antibiotics doesn't get rid of the toxin. He had diminished breath sounds in the left lung, pulmonary infiltrates, and enlargement of the epiglottis. He had yellow exudate on the tonsils, posterior pharynx, and soft palate. Admitted to the ICU, treated with a whole host of antibiotics and steroids to dampen the inflammatory response. Remember, some inflammation is good, too much inflammation is bad. If you have the epiglottis start to inflame, that is bad. Over the next 4 days, he became hypotensive with a fever. Cultures were negative. By the 8th day of illness, the chest x-ray showed infiltration in both the right and left lung, and an exudate consistent with Corynebacterium diphtheriae pseudomembrane was observed over the supraglottic structures. Cultures were still negative, but PCR for the exotoxin gene was positive. Despite aggressive therapy, the patient continued to deteriorate, and on the 17th day of hospitalization, he developed cardiac complications and died. This patient illustrates the risk factor of an unimmunized patient traveling to an endemic area, the classic presentation of severe respiratory diphtheria, those upper respiratory infection, the lung infiltration, the production of the pseudomembrane, the delays associated with the diagnosis of an uncommon disease, and the difficulties most laboratories would now have isolating the organism in culture. I told you previously that it will grow on blood agar, and there is specialized agar that will grow Corynebacterium diphtheriae. The challenge is most physicians, unless they are well aware of that pseudomembrane, will try to culture just on standard growth media, maybe like blood agar. Lots of things grow on blood agar, and the organisms of the upper respiratory tract, that normal microbiome, could outcompete diphtheria on that plate. So in the absence of using that specialized media, the only way they were able to diagnose it is until they were like, oh, wait, by the way, pseudomembrane, that's kind of weird. Maybe we should test directly for Corynebacterium diphtheriae. So because it took so long, the patient didn't really have much of a chance. So again, the infection can be diagnosed by culture, nucleic acid, and biochemical assays, but that pseudomembrane is unique. It's one of those things that if you are a physician, especially if you know the patient history, that the patient isn't vaccinated, if they show up with a pseudomembrane, it's diphtheria. One of the other symptoms that can be really diagnostic, they call it bull neck, like the neck kind of swells. So if the patient's neck is swollen and they have a pseudomembrane, it's basically like their body is screaming, we have diphtheria. That's the only thing that'll cause it. If a patient is suspected to have diphtheria, like the previous patient who had diphtheria, but they didn't diagnose it until way too late. If they had diagnosed it right at first when that patient showed up at the hospital, they could have tried to treat that patient with antibiotic therapy in conjunction with diphtheria antitoxin, which could have helped clear the infection and neutralize the toxin that had already formed and may have given that patient a better chance. Antibiotics will work. There isn't really a lot of antibiotic resistance. The bacterium doesn't go intracellular, so you're not worried about that. But of course, the best thing to do is be vaccinated. And the vaccine is not against the organism itself. The vaccine is against the diphtheria toxin produced. So very, very critical. Diphtheria does have an interesting history in the US. You may have heard of the Iditarod, the dog sled race that takes place in Alaska. The Iditarod actually has its origins in a 1925 serum run. So in January, I believe it was January of 1925, a diphtheria outbreak hit Nome, Alaska, which is up here. Really, really cold in Nome. There can be ice that forms out here, preventing shipping. The weather is not great for airplanes, and remember this was 1925. And now we have diphtheria. There is no vaccine. All there is antiserum. That's what's given to patients who are diagnosed with diphtheria at the time. Well, there was a shipment of diphtheria serum that was able to come up from Seattle, but it couldn't go to Nome because of the ice. However, there's this area in Seward, Alaska, down here kind of near Anchorage, where the ice doesn't form. It's just far enough south that there's no ice, so ships can get here. But then the challenge is, well, how do you get the serum to Nome? So they took it up by railroad to this town here, Nenana, and then a series of dog sledders, mushers, 20 of them, ran the serum to Nome to help treat people. This really illustrates how dangerous this infection is, that Nome was going to lose children, lots and lots of children, that people were willing to risk their lives to get on dog sleds in the middle of January in Alaska to take this serum to treat these patients. So if you've heard of Balto, that was one of the dogs that led one of the teams. If you ever go to Alaska, the dog sled areas are really into describing how this worked. And so we happened to go to Alaska a few years ago, and we were down in Seward, and they have a dog training and dog rearing facility for the dog sledding. And they have signs describing what the Iditarod was used for. Originally, the trails were used to transport supplies, transport mail, transport gold. But then a portion of the trail was used by 20 mushers to relay diphtheria serum to Nome in 1925. And so the Iditarod is commemorative of that serum run. And you can hold the puppies that will eventually become sled dogs, and you can even be pulled by sled dogs. When we went, it was the summer, so that's why there's really in southern Alaska, there's really no snow on the ground, and the dogs actually will pull you in a wheeled cart. So the history of why we need vaccines is really important. People were willing to risk their lives to take this serum, and now we have a vaccine, so we don't need the serum. Those of you going into medicine really want to emphasize the public health aspects of how important vaccination is. Even if we think these diseases aren't around anymore, they still are, and it's still important to be vaccinated.